All right. Welcome everybody. My name is Robert Down. I'm one of the project administrators here. And in this lecture series today, I want to talk a little bit about the clinical workflow in the acute care inpatient setting. Specifically kind of looking at what a nurse's relationship to the EMR is and what they're doing throughout the day. A little bit maybe about what a doctor's workflow would be, although I am a nurse by trade, so it'll be focused on the clinical nurse. A little bit quick, just bio about me. I'm a software developer turned nurse, and I'm trying to mesh those two worlds together. Just finished up grad school and in the process of starting a health IT startup, effectively software as a service that leverages OpenEMR for cloud-based school nursing and veterinary medicine. You can find me on LinkedIn and the company website on those QR codes. And as far as slides go, that's really all I've got. I thought about making this big, elaborate outline, and I figured it'd be better just kind of walk you through what a day in the life of a clinical nurse is. Currently, I am a travel nurse. So aside from the software firm that I'm trying to start, my day job is still at the bedside, taking care of patients. Although this particular travel nurse assignment, I've spent a lot of time on as a charge nurse, so kind of managing a one nursing unit. Still very close to patient care. And in terms of acuity, most of my time is spent on a progressive care unit, which is just below intensive care. It's still part of the field of critical care nursing. I've done assignments on lower acuity floors that are a bit more stable patients. But most of my time as a nurse has been spent with patients who are, can be best described as stable, but can quickly become unstable. Whereas your ICU patients tend to be just unstable. And then your lower acuity patients are stable, and there's really no indication that they're going to become unstable at any time. Of course, things can change over a hospital visit. But yeah, that's kind of where I am in my background, and I'm going to stop sharing because that's really the only two slides that I had. So most of this talk, the context will be what a bedside nurse is doing day to day in a hospital. It'll all be inpatient focused. This is not workflows for doctors' offices or outpatient settings. It's very much what the clinician is doing in a hospital day to day to take care of patients, and a bit of how the EMR interacts with their day-to-day lives. And the reason I wanted to present this topic is because I feel like we've got a ton of really good developers here. We're very software centric in our conversations, which we should be. I mean, we're software after all. But I've heard a couple of times that we don't necessarily have a ton of clinical experience, and that makes a whole lot of sense. If you get really good software developers, they've probably spent their time in software. And so I thought I wanted to present some of my experiences because I am lucky enough to be able to speak both languages, the clinical side, as well as the software side. So hopefully kind of help contextualize what all of the work that we do on the software, how it interplays and works on the other side. And so for me as a nurse, I break down my day into really kind of three big buckets. And it's almost all time management. And so the first bucket is pretty much the start of the shift for the first 4 hours, so about 11. So inpatient nurses generally work 12-hour shifts, 7 to 7. And then they hand off for a night shift from 7 p.m. to 7 a.m. And so those first 4 hours, for me, between 7 and 11, is kind of like my bucket one. 11 to 3-ish is bucket 2, and then 3 to 7, kind of that last bucket of time. And it helps me kind of break down what my day will look like. And and keeping on track of the tasks and things that I have to get done. And so when I arrive to the unit and kind of get going between 7 a.m. or p.m. really, between 7 and 8, it is almost 100% information acquisition. I sit down, I'm handed a list of patients. In my acuity, it's generally anywhere from 3 to 5 patients. Lower acuity nurses may take care of up to 7 patients, and higher acuity may actually have 2 nurses taking care of 1 patient, because that's how complex their medical needs are. So there's kind of this broad spectrum, but I would say anywhere from 2 to 5 patients is reasonable for any given nurse. And the first half hour, 45 minutes is really just nothing but information acquisition. Who am I taking care of? What are they here for? What do their labs look like? What medications are upcoming? What do the latest doctor's notes say? So every single day, physicians or providers like Brady will come by, see a patient, write a progress note. And it's not uncommon to have a hospitalist who's the kind of the quarterback of the team, and then maybe three consults. Brady for an oncologist, or maybe there's a pulmonologist or a nephrologist. And each of those specialists will be writing notes. And so really the first few minutes of my day are really quickly and rapidly grabbing summaries out of those notes to understand from a pulmonologist's perspective, what do I need, what's on my radar, what do I need to be looking for? Critical things are generally, especially if I'm unfamiliar with a patient, the history, the H&P, history and physical, because it'll give me a quick snapshot of kind of the state of the health of the patient with that before they got to the hospital. And then getting a report from the previous nurse will kind of give me the snapshot of where are they at right now. And that helps me build and kind of paint this clinical picture of the patient before I even step foot in the room. And I've noticed when I sit down, and I will admit my workflow has changed. I've experienced in Cerner, and the way I went about information acquisition has changed as I shifted from Cerner over to Epic, and how I would acquire information even in OpenEMR is different. But some key things that I look for that I really need to know immediately about every patient that I take care of is who they are and how I can identify them. So their name, their date of birth, and whatever their medical record number may be. And I would say the second most important thing is, can I resuscitate them? If their heart stops for any reason, do I have the legal authority to attempt to bring them back? And OpenEMR supports advanced directives and do not resuscitate orders. And that's always one of the first things that I go to and look. Most systems have it pretty quickly accessible because in that moment, we really need to know with confidence whether we can or cannot intervene. Once those two things are done, I really need to know, why are they here? Did they come in for pneumonia? Did they come in for COVID? Did they fall and hit their head? And that's usually pulled out of the history and physical, or more commonly just from the nurse, the previous nurse. And then me personally, I know a lot of nurses also want to know a quick set of lab work. The most recent lab work, I don't care about lab work from 3 days ago at this point or a week ago. I care about what lab work was most recent, and a few different values out of that, some electrolytes and different values that have really impactful clinical meaning, so that when I step foot in, if I know that a particular lab value is high or low, I can walk into the room and kind of justify with what I'm seeing in the patient and be aware if we need to intervene. Based on those lab values, I may actually shift my priorities for the morning before I even step foot in the room. If they've got really out of line potassium, for instance, that has not been addressed, or that just resulted in the last few minutes, that may shift my workflow and what I need to do to care for the patient. And so being able to quickly ascertain those lab values is actually pretty crucial for me. And really after that, once I feel like I've got enough knowledge to get the day going, it very quickly becomes, again, more rapid. But instead of information acquisition, now I'm doing rapid assessments on my patients. I'm going in, introducing myself, and kind of laying the groundwork for the way the day is going to go, and stepping away from the computer and away from the information and talking to the patient. It's usually pretty quick. I can do a head-to-toe assessment on a patient, including getting their vital signs and checking everything from their neurological status to every other, basically every other body system, in about 5 minutes. And what this lets me do is validate the data that I've seen in the EMR and in the system, and further paint out that clinical picture of the patient. It needs to be quick because I need to know as much as I can about all of my patients really as quickly as I can to ensure that pressing concerns are addressed. And so I'll go from room to room, kind of robotic. I have my own kind of script that I have when I go in and talk to patients, and it helps me fill in the dots that maybe the report couldn't from the previous nurse, or like I said, just kind of paint that clinical picture. And that is about an hour's worth of time. And I've not really done a whole lot, but yet I've acquired a ton of information, a lot of it from the computer, a lot of it from the EMR, and a lot of it just straight from the patient. Generally, at that point, we move into medication administration time. So a lot of hospitals, medication administration is, for the most part, begins at 8 or 9-ish, and it runs for a couple of hours. We have a nice big window for most medications. As you get into higher acuity, you may run into quite a few medications that are not that are more sensitive to time administration. If we're administering IV medications that are keeping your blood pressure at a certain level, those need to be replaced and maintained at very specific times. If you take cardiac medication, those have very tight windows of administration. For the most part, a lot of medications, though, that we give, especially like your morning pills, if you take a few of them, can be given in this window. And so after I've met everybody and I've read about everybody, I come back to the EMR, I sit down and I quickly glance at everything, all the meds that I've got to give, and I can prioritize who do I need to see first, who has medications that can't be, we can't deviate too much from the time, and who has medications that we can. A lot of times the way, especially in the inpatient setting, medications may fall, for whatever reason, medication may be due at 8 a.m. and then another medication might be due at 9 a.m. to be given twice a day. And if that medication due at 8 a.m. it's just a medication we give once a day, no big deal. It's something the patient takes at home, a baby aspirin or something. And perhaps we're giving them an antibiotic at 9 a.m. that they're taking twice a day. Instead of going in that room twice, I generally will message our pharmacist and get things rescheduled so that they line up at the same time. And so a lot of that time is as I'm preparing and pulling medications out of the automated dispensing machines. I'm also trying to line up the times to help streamline my process. So there are medications that I can't deviate from, and that just, it is what it is. You go in and you give it when it's due, but I do my best, especially in the mornings, to line everything up so that I can walk in and administer all of the medications that I can in one time. And that's not to avoid being at the patient's bedside by any means. It's to maximize the available time that I have to be flexible and respond to changing circumstances, and circumstances will always change in the hospital. So I spend anywhere from an hour to 90 minutes doing medications. And that involves interacting with the EMR, usually at the automatic dispensing machine, which is very much, if you're not familiar, it's basically a vending machine for medications that can be controlled in a very auditable way. And I can pull anything from a couple of Tylenol to pretty heavy duty narcotics. They're usually in little cubbies that pop open, like a drawer pops out, the cubbies open and they're secured. There's big towers with doors that just kind of swing open, kind of like a cabinet in the kitchen. And oftentimes there's a refrigerator that's locked that is all kind of managed by this machine. And you log in and you pull up your patient and kind of grab the meds as needed. And understanding what I'm pulling, I usually have the EMR sitting right next to me at that workstation. I'm looking to make sure what I'm giving is right. I'm pulling off the machine and head into each patient's room, where I spend time, again, at the EMR side by side with the patient, verifying who they are. And at least in every hospital setting I've ever worked in, barcode, BCMA barcode, I forget what the C stands for. Barcode scanned administration is basically a requirement at this point. So I scan the patient's wristband, I scan the patient's medication, and the EMR does an ad hoc verification process. It says, yep, this medication is good to go. It helps protect some of the 5 rights that a patient has around medication administration. And most hospitals, most informatics departments track that to see if a particular nurse is not remaining compliant with how many barcodes they're scanning versus how many medications they're administering. It may warrant a conversation about the importance of scanning those barcodes. It doesn't always work. I have found that it's actually a pretty big barrier to a successful morning at the bedside. A lot of times your scanner doesn't work, or the medication, the barcode is not reading properly. So a lot of times we kind of bypass that, and it's a pretty big spot for nurses to make mistakes. And so generally I always try to ensure that things are scanned appropriately. The other benefit to scanning is if you're hanging an IV medication, you can oftentimes scan the medication and then scan the IV pump, and it will automatically program the pump based on the information in the MAR, or the medication administration record that exists within the EMR. So you scan the patient, you scan the medication, you scan the pump, and the EMR will push down all that information, I would imagine, in an HL7 feed, but I really don't know the details about how that happens. But the IV pump gets automatically programmed with the right medication, the right dose, the right rate, and then all I do as a nurse is verify that the information is correct and then run it. Some great side rails to medication administration, and it really streamlines some of that process. But again, my time is probably split between talking to the patient about these medications, making sure that they know what's being given, and interfacing with the EMR at the bedside. Once that is done, I will continue on and do that for all the patients. And in this conversation, everything is happening in a perfect world. All the medications are scanned appropriately. The Pyxis or Omnicell or the medication vending machines. Oftentimes you'll go to one, and this one medication won't be in that machine. You'll have to go down the hall to the next one. And so you go down there. And in between all of that, you've answered 4 call bells because you have patients who need something, patients who need to go to the restroom and cannot physically safely walk themselves. So you have to help assist them. Patients who want water or breakfast, patients' families who call and wanting updates. And so you're dealing with some of that in the midst of this process. So generally the workflow that I'm describing is a perfect world, but it rarely works like that. There's usually a lot of distractions at all times for the most part. And so usually by about 10, on a day where there's been no emergencies, by about 10, I've completed my medication passes. I've assessed everybody and have addressed hopefully any concerns that I have. And then it becomes sitting back down at the nurse's station and diving into the EMR to chart everything that's happened. So the medications have been charted in real time when I'm scanning everything at the bedside, but the assessments that I've completed have not been charted. And so those usually go into a flow sheet that gets back time to whenever I physically did the assessment, and I chart everything. The first time around, you chart every body system, and even if there's nothing wrong, say a patient came in because they fell and broke their arm, you still have to at least acknowledge in the EMR that you did a neurological exam and it was fine. They were within defined limits or within normal limits, which is a very quick process. Some institutions have policies that require each assessment field be charted. Even if the data is within normal limits, you need to specify that they are within normal limits. And it kind of deviates, and this is usually at the institutional level. And I can chart your respiratory system as your lungs sound clear, they're equal, and there's probably a couple other points. And some institutions say, well, you have to chart every one of those points. Many institutions at this time, especially I think in the world of COVID, have basically said, no, if you listen to their lungs and everything is fine, everything is normal, you can just say within normal limits at one time at the top, basically say their entire respiratory system is within normal limits, and you move on. Institutions that have adopted that and adopted that best practice, documentation seems to go a lot faster and you're bogged down a lot less. However, not everybody does, and it can really slow down the documentation process. So usually I spend 45 minutes to an hour in the chart doing nothing but assessment data. And that includes things that are really pertinent to the care of the patient, and it will honestly include a lot of compliance charting as well. That's one of the reasons that nurses chart, really anybody charts, because there's critical information to pass to the next provider or that needs to be notated. But one reason we chart is absolutely to meet compliance requirements. And so some of my time is spent doing that, and there's really no way, unfortunately, to kind of mitigate some of that charting needs. At that time, it's about 10:30, 11 o'clock at this time. Hopefully some physicians or providers have swung by and assessed the patient themselves, and maybe they're putting in progress notes or adding medications or changing some things. So usually there's some changes that have to happen, and I may have to go back into a patient's room and administer more medications, or guaranteed I've answered a few more call bells at that point, or call lights. And really maybe just assist another nurse if they're really struggling. And so at that point, we're kind of into, that's all block one, right? That's the first 4 hours of my day. And it's usually pretty fast paced. When I was a night shift nurse, it was pretty much a sprint to 11 o'clock, because at 11 o'clock, you want your patients to go to sleep to get some kind of rest. But even in the morning, you're spent, those first 4 hours are spent running around trying to get everybody settled, making sure that if your patient has diabetes and the breakfast trays have arrived, that you've taken their blood sugar, you've given them the appropriate insulin that they need to be able to continue basic things like eating breakfast. Because if you don't do that, then if they manage their own insulin at home, but they don't have, they can't manage that in the hospital, it's on you. And it's a lot of running around and really just trying to get everybody settled for a good day is how I like to think about it. And then finally, by about 11 o'clock, in an ideal world, things can kind of slow down, and you have the ability to take a breath, maybe grab some food, drink some water, make sure nobody else is really struggling on the unit. But then at the acuity level that I care for, you generally require assessments every 4 hours. So if it's now 11 o'clock in the morning, my last assessment was about 8. I got to start thinking about starting that process over again. I usually try to get my assessment started by 7:30 in the morning. So by 11:30, it's time to do it all over again. So I'm back in patient's room doing blood pressures and temperatures and making sure that their needs are being met and that they haven't changed clinically. For ICU patients, the assessments are usually more like every hour to every 30 minutes, depending on really how unstable they are. So their time management's even a little different. Although the trade-off is generally a lot of ICU patients are not require different care. So if patients are ventilated and we're breathing for them, basically, we manage a lot more of the medications that are driving all of that care. They're not running around to call bells and call lights, and nobody's getting out of the bed to help go to the restroom. Care is a little different. And on lower acuity units, those first few hours are generally even busier, because the lower the acuity of a patient, the more likely are that they're really very close to their own activities of daily living. So they want to get up and use the bathroom. They want to get up and watch TV. They want to get up and make sure that their medications are given when they usually take them, and have breakfast. And so, all of that is a little different depending on the acuity of care. But like I was saying, for me, who's kind of in the middle between your most sick patients and your most stable patients, by about 11:30, I'm starting the process over again and redoing my assessments. Generally, assessments happen a lot faster. Now I know my baseline of my patients. I'm able to compare to what I'm seeing now from what I saw 4 hours ago. And that's helpful. It speeds the process up. And charting a reassessment, especially I've noticed over the last couple of years, has really become only charting things that have changed. There's no reason to continue to chart everything every single time. Most EMRs in the hospital have the ability to pull forward or kind of copy and paste a previous assessment, which is generally accepted practice as long as you ensure that what you're copying is correct. So I personally don't really copy other nurses' assessment data. I will chart my own and then copy my own. And that's usually the practice I see most nurses doing. And assuming nothing has changed in my patients, redocumenting those assessment changes is pretty straightforward. It can be done a lot quicker. It can be done more efficiently, and sometimes even done at the bedside as you're talking to the patient. And you kind of repeat that process again. Lunch trays are there, so your diabetic patients need to have their blood sugar checked again, and more physicians are swung by. It's not uncommon to have the physical therapist or occupational therapist or speech therapist, or any of the imaging departments want to come by and do some imaging, so you're interfacing with them, allowing the physical therapist to work with your patients to get better, maybe interacting with the case manager to discuss discharge planning. And so a lot of that happens between 11 and about 3. You're trying to figure out, can my patient's level of care be downgraded? Are we taking a step closer to the discharge process, or are they actually getting worse and we need to consider upgrading their level of care to a different level? So maybe they need to be in the ICU. Maybe those first 4 hours did not go very well. And so you're spending a lot of time trying to figure out where they are, and where they're trying to go, and are the actions we're taking getting them there. That's roughly about half the day. I feel like I've talked for a long time and I've only covered half the day. Brady, are there any questions in the chat? Break the monotony here for a second. Any questions so far?
Yeah, it looks like Stephen Nielsen has one about, looks like in your bucket 1 period, when you're gathering information before you see patients, do you get most of that initial information from the EMR, or is there some information that is only conveyed from prior staff and then must be entered by you in the EMR before seeing patients?
Clinically, most, I don't know what kind of report I'm going to get every morning. Every nurse is different. Some nurses want to give you the whole life story of a patient. Other nurses are going to tell you what they saw on their shift. So you have to take a report from the previous nurse. And I take it all with a grain of salt, with the understanding that what they have seen on their shift may not be what I see on my shift. Some of the objective data that has very little room for interpretation, those lab works, the lab results, the scheduled medications, kind of the provider's position, all of that comes from the chart, from the EMR itself. And then what I have found generally is you get some of those soft assessment points from the previous nurse. I don't go back and chart anything that a previous nurse told me. If you didn't see it or do it, you can't chart on it, because the minute you put that chart, that data in the chart with a legally binding document there, you're saying like, I saw this, I did this, I completed this task. And so if another nurse says, oh, I saw this, but I didn't chart it, I either say, okay, can you put it in the chart? Or I just make a mental note of it to help paint the picture, but I don't go back in and put a charted assessment chart. I don't put anything in the chart that the previous shift did. The only exception would be if it's like a safety concern, I might say, like per the previous nurse, blah, blah, blah. But even then, I don't really do that. But what the value that I pull from that shift change report with the nurse is the soft data that you can't adequately capture in the EMR. Especially if there's interpersonal things with a patient that maybe helps our care. So things about the patient that we could bring up and discuss. Conversations that the nurse maybe had with the physician, but the physician hasn't put the notes in yet, things to kind of be aware of, that type of thing. Some of those softer skills, or even if there's things that need to be avoided with the patient, hey, we were talking and this topic came up and it didn't go very well, and maybe avoid that. There's really no good place for that in the EMR. There probably shouldn't be a place for that. But that's the kind of thing that happens in the nurse-to-nurse report. But all of the objective stuff, lab values, medications, that all happens right out of the chart. And I'll usually take a report from the nurse first, because I know that they've been there for 12 hours, so they want to get out of here. So I take a report and let them move on to giving to the next report or getting out the door. And then I sit in front of the computer and pull data from there. I think somebody else, I saw the chat notification just popped up.
Yeah, I think Stephen's just happy with the answer. He said thank you. And I guess anyone else had questions before you move on to, sounds like we're moving on to bucket 3 soon, but if anyone has questions. I guess we're all good.
Yeah. So really by about 1 p.m., hopefully you're settled and you feel confident with your understanding of your patients. I see that as far as I guess the question would be, well, let me read that again.
Is this the question by John? It looks like,
Yeah.
So John posted, as far as OpenEMR is concerned, are these charts built in or track anything?
I don't know if, they could be track anything. I think honestly, OpenEMR would benefit from a flow sheet model. That's pretty much what I've seen in Cerner. That's what I've seen in Epic. And that is how nurse charting and assessment data was charted even before EMRs existed, on pen and paper. It certainly could be track anything. A lot of the assessment data is text-based, and then so I guess you could use track anything. And then we have the ability in OpenEMR to already have lab results pulled back, and then vital signs tend to be graphable and tracked as well. That's kind of already built in. So there's definitely an opportunity for OpenEMR to improve how inpatient care is done, because a lot of the assessment data is flow sheet based. Other than that, a lot of the information I gather would just come out of a particular, probably layout based form that the physician is using to write the note, and then I'm just pulling information off of that, like a nation note type of thing. So usually, like I say, by about 1, you're pretty confident with kind of with your patient, with your care. And then you end up doing a lot of miscellaneous tasks, talking to physicians, trying to either advocate for a different care plan if you don't think it's working, or I guess I was saying interfacing with a care manager because it looks like we're heading out the door. And then usually by about 3, you kind of start that reassessment data over, reassessment again, where you're doing a set of vital signs, you're doing another quick assessment on your patients, and you're getting that into the chart. Again, just like your second time around, you pull it through, you kind of copy and make your changes as necessary. And that's in a perfect world where everybody is stable. Usually there's another medication time. About 5-ish is a very common time to give medications. So there'll be usually another medication passed around that time. It's usually not as intense as your 9 a.m. one. It's the 9 a.m. medication pass can sometimes, a single patient may have 17 different medications to give. That's not uncommon at all. It's a lot in the morning. Usually in the 5 o'clock one, it's a medication that needs to be given with meals. So maybe breakfast and dinner, that type of thing. I saw another question come in. Goals and care plans, nice. And then really, as the afternoon progresses, what my focus becomes on is usually reviewing the notes that were written by the provider that day. So in the morning, I read yesterday's notes. Now I want to read today's notes so that I understand what the plan is moving forward, so that when I give report to the next nurse, I can tell them what the plan is, right? They know what's going on and what to expect for the night or for the day. Night shift doesn't have anybody rounding usually, so they kind of just read a progress note, and that is the care plan for the day. And then it's really just managing a lot of activities of daily living for the patients, helping them, kind of addressing their needs. A lot of times, those medications that are scheduled, so 9 a.m., 5 p.m., those are routine medications, but very often we're doing a lot of pain management. So those medication passes are usually every 3 or 4 hours. So maybe I'm in there doing pain management. And that's roughly what a day is, in a perfect world where everything goes right. I spend a lot of time in the EMR when things don't go right. And I think the best way to put my relationship, what my relationship is with the EMR as a nurse when I'm working in the morning, I need information and I need it now. The rest of the day, whatever, I can kind of meander through the chart and find what I need. But when something goes wrong or we're in an emergent situation, I'm back to, I need information and I need it now. And I think that there's a lot of opportunity for the EMR to get in the way of that, but there's a lot of opportunity for the EMR to present the data that I need quickly and concisely, and in a fashion that helps me pull the data that I need to address the issue at hand. Because in an emergency, I don't want to be fiddling with the EMR. I want to be able to take care of the patient. There are everywhere I've ever worked, when you don't scan a medication, the system will ask you, hey, you didn't scan this, why not? And you have to provide an override reason. And every one of them has an emergency override option that just says, it was an emergency, I'm not messing with you, And I think that that kind of goes to show, in a lot of times, we need the EMR to get out of the way. I need the information, but a lot of times I need it out of I need what I need, and I need to not worry about everything else, because there's so much information in the EMR and in a person's chart that is ancillary to the care that I'm providing. There's, if you think about why the EMR exists, yes, it's to drive patient care, but a whole lot of the reason is insurance and reimbursements and to get paid appropriately. And I don't think that's that's not even a well-kept secret. It's not even a secret. I think we've just kind of accepted that as fact today, that in the chart exists, the chart exists for insurance companies and for reimbursement departments, in addition to the data that I need. And so ensuring that the EMR can give me the data that I need as a direct care nurse and get out of my way with the other stuff is pretty critical to the workflow. Yes, medical legal reasons for sure. I think I was on a call a few weeks back with the American Nursing Informatics Association. I think they listed 6 reasons that that we chart: medical legal, patient care, reimbursements, and there were a few others. But yeah, absolutely. Without a good paper trail, that's a mechanism for ensuring quality, and that's one of the other reasons. Like quality, if we don't chart it, we can't review it and analyze it and do better next time. And so I think there's opportunities. I think specifically to how Epic has kind of built out their context in a lot of ways. I don't know who is or isn't familiar, but the view that I get in Epic when I log in to a patient's chart is geared towards the inpatient nurse. It's geared towards the things that I do every day, and I still don't think it's as good as it could be. But it's very different than what the data that I see is different than the data that a biller might see, or somebody in like a reimbursement role who's checking coding. What they need is different, and I'm sure even what Brady sees when he logs in is a little different, because his workflow is different. He's generating data in I don't even know what the note writers in Cerner it's called Power Note. Brady spends a lot of time writing the notes. I spend a lot of time pulling out data from the notes, and so the views that we have in our roles kind of change to match the workflow. Even when I'm a charge nurse and don't actually have patients, that I'm not caring for patients, I'm managing a unit, and I'm managing a team of nurses. My workflow is a little different, and the EMR is flexible enough to meet those needs of the different workflows. So I didn't want to spend the whole time sitting here just talking about like a day in the life of the nurse, but I wanted to do that, but I didn't want to forego the relationship that I have with the chart. I'm always logged into the chart. I'm always logged into Epic. If I'm sitting down at the computer, I'm logged into Epic. If I'm in the patient's room, I'm probably logged into Epic. I would love to know. I would love to see a. I can't remember the name of the graph. Not a burn rate, a heat map. I'd love to see a heat map of all of the places that in time that I spend in the chart, because I'm in there an obnoxious amount of time. As a care nurse, as a charge nurse, I'm only in Epic. I mean, that's just all I do, or even Cerner. And so when I don't think anybody can talk about what a day in the life of an inpatient nurse is, or even an outpatient nurse, you can't talk about a day in the life of a clinician and not talk about the relationship that they have with the EMR. And I think, yeah, I can get on a high horse about in the soapbox about some of the things that EMRs do that get in the way, but maybe I'll save that for another talk. Are there any questions there anything, any questions? I know as developers sometimes, like I wonder, these changes that I'm doing, is anybody listening? Does anybody care? Does it impact anybody? Or is it getting in the way, which is something I definitely want to avoid. Are there any more questions? Anything come through, Brady, in the chat?
Yeah, no, nothing in the chat, but yeah, it was really nice. I think it gives everybody an idea of sort of how things are working on the clinician side and provider side.
Do you?
Although here's a question from Steven. Oh, he was going to ask you, what workflow features in an EMR do you find to be the most helpful to your day-to-day job? What do you find that get in your way most in your day-to-day job? Kind of what you were going to allude to.
So,
and John had the same question, basically. What's getting in the way? Or yeah, what gets in the way? So it sounds like there's a lot of interest in what gets in the way.
What gets in the way? So I've not worked in Cerner for a couple of years now. So a lot of my experience, I've never worked in Meditech, I've never worked in Athena. My most recent experience has been in Epic. And I think Epic does a lot of really good things. Things that get in my way are 100% redundant alarms within the EMR. So when I was prepping this talk, I actually considered, and I couldn't think of a good way to do this, but there's some background noise loops on YouTube of business settings and offices. And one of them is of a hospital. And I don't know how many times, how much time anybody has spent in a hospital as patient or as family, but at the nurse's station, I can pretty much guarantee that in a lot of units, maybe not all of them, but in a lot of units, there's nothing but alarms going off all day long. And a lot of times they're informational, and sometimes they're like, something's very, very wrong. We need to address this right now. A lot of times, specifically, it's from a cardiac monitoring. So a lot of patients were concerned about making sure that their heart is in the right rhythm. And so we put some stickers on your chest and we hook it up to a machine that can monitor your heart rate in real time. And then we can sit at our nurse's station and we have got a computer that shows the rhythms of everybody. And so if you think on like a 20-bed unit, maybe 18 people have that telemetry. Maybe there's like 3 people who are truly don't need it, but almost everybody has it. And that machine, it's always going off. Because when you got 20 people on telemetry monitoring, people move, the machine loses good signal, so it beeps at you, hey, I lost good signal for a second, or maybe my oxygen levels of a patient has gone down, or my heart rate has gone up. There's a whole bunch of reasons that can trigger alarms. And we hear that all day long, to the point where I don't even have to look at the monitor. I can hear the alarm and I know in my head, I can ignore that one. But it's still there. It's basically nonstop. The other alarm that we hear all the time is when you push the call light, the call bell on the remote in the patient's room, it rings out to the nurse's station, and it sounds like a bell, and it just rings every few seconds until somebody answers it, which is fine. But then again, multiply that by 20 patients, and there's usually somebody who needs something. So call bells are pretty ubiquitous and they're pretty common. And there's very little I can do to avoid those because they're auditory. I can't not hear. But when I log into a patient's chart and I'm looking at the summary screen, which kind of is give me the high level information that I'm looking for real quick, to see, there's various alarms and alerts that show up in the chart. The most common one, this patient has a high fall risk. There's various assessment data that will calculate a score using some different mechanisms. And if your score is high enough, you're considered a fall risk. And so bam, you've got this full width alert that'll say this patient's at a high risk for fall, some variation of it. Interestingly, if you're at a high risk for fall, you're probably already at a high risk for injury if a fall occurs, but I see that one too. So you're at a high risk of injury if you fall. Well, that's kind of redundant. Everybody's at high risk for injury if you fall. If you fall out of bed, there's a good chance you're going to get hurt. But now I've got two alarms, two alerts. There's, if you're a bit older, maybe you're not eating very well, you're at risk for skin breakdown. If you're just laying in bed not moving, you can develop bed sores. If your assessment data triggers the right score, that's another banner. So very quickly, I can end up with 7 or 8 full width single line alerts, to the point where I can't even see anything about the patient other than these alerts. And that is something that absolutely gets in the way. And what ends up happening is you start to ignore them. And that's just, it's not me saying that, it's the industry. Alarm fatigue is a thing that I'm sure Brady's dealt with. It's something I deal with. Any other physicians on this call have probably dealt with too. When there's just so many alerts and alarms going off, we have to just kind of push them away and defer them, and that's problematic. So that is by far one of the biggest things. The other thing would be, from a UX perspective, not getting me the information, like not bringing the most pertinent information to the top. One of the features that I've come to really like, I didn't really care a whole lot when I first started using Epic, and I do now. I love it. We have in OpenEMR, our patient banner bar is on the top of the screen. It's horizontal. For the most of the time in Epic, it's vertical on the left side. And on the left side, you can hover over some text. It's about lab work over the last, I don't know, 24 hours, say. And all I have to do is hover over that text, and I get a big pop-up that will show most of the lab work and everything I need. That's super pertinent. And what that does is it saves me at least one click to change the view to load up those results. And that one click, it doesn't sound like a lot, but that click generally takes a long time to load because you're loading a lot of data. And so to be able to never even leave that summary screen and just hover over it, that's a way that they've basically reduced my click count. And I'm still able to get that super important information. I would love to see, I don't know if there's a good way to do this, but I'd love to see like hover to discover the latest progress note written by whatever specialty. I can just hover over and see the latest note that Brady has written. I don't have to click, because that would be one click to change screens, load up all the notes, another click to go into the note, scroll down and read it. From a UX perspective, that is both something that gets in the way and that Epic deals with very well. From a user perspective, one thing that I've noticed, and Brady can probably speak a little bit more to this than I could, physicians have a nasty habit of copying their previous notes over. And a lot of times the notes get populated with everything that the physician wants to, like, they cover everything, even if it's not necessarily pertinent. So they'll put in a template that pulls in all of the lab values from yesterday and all of the imaging that they've ever had at this encounter, and the patient's history and all kinds of stuff that I think gets put in the progress notes as probably like a liability, medical legal type of thing. When in reality, when I'm reading a physician's note, I just want to know what your assessment was and what the plan is. And that's not at any particular physician. I see it from all providers. And it really depends on how the institution has set up their note writing platform. Because I know for the physician, to have all of that information in a note makes it easy for them to see, but then it makes information extraction a little more difficult when I'm trying to like sort through a bunch of things that is in every single note that I don't care about.
Yeah. From a physician perspective, a lot of that's also to help just remember the big picture, but also when other physicians take over a cover, they can just read it. But usually what providers try to do, the problem is there's no standard, is they try and put that assessment part, the real important part, in one place in the note consistently. So usually it's either at the end or at the beginning. That's usually how that works. So
Yeah.
Usually you want to look for that one spot and you ignore all the rest if you're really just looking for for what's going on with the plan.
Yeah. And I'm sure that there is value, especially during the physician handoff. And that's where things get even more complex. I can walk up to you and say, this is how you solve the problem for nurses. And that would blow up the provider workflow. And Brady can sit down and go, I know how to solve the problem for doctors. And it would blow up my workflow as a nurse. And so, I think, which is part of the reason that institutions that do better, I think, are institutions that leverage an interdisciplinary informatics program, where Brady and I both sit down at the table and we go, okay, we've got this new feature we want to roll out. How do we make it work for as many people as we can? When you silo out your informatics departments and you've got physician informatics and nursing informatics and they never talk to each other, that's where more barriers come up to exist. To close the loop, John, yes, all of those are displayed in the EMR itself. I've been at places that can integrate, there's like smartphone apps now that are HIPAA compliant that do messaging. And I've seen those messages come to those notifications on phones and stuff, but the alerts that I was speaking of are directly about, like, when I open up the EMR, I'm looking at the patient summary screen and I'm just trying to grab some quick information. That's where I get the long list of alerts.
It looks like Stephen has a question. Pretty good. It looks like, do you work for the EMR?
Oh, yeah,
work with extract all the data with these textual notes. It sounds like most of these notes you're reading are text-based. Is that correct? I'm guessing they are, but.
Yes. So most of the notes that I read, I'm sure Cerner had something similar, but within Epic, when you have the note writer open, you can do some templating. So I think, I don't do it myself a whole lot, but I think you can basically do like an @ lab. And when you sign a note, Epic will just replace that out with the latest lab results of the last 24 hours. And it's all very customizable. You can make your own macros, basically. So it's this hybrid approach of new textual data, previous textual data that you've copied over, macro-based, go get objective, discrete data from the lab and put it into a text-based form, and imaging. Imaging notes are also text-based, and they'll just pull it in as well. Most of it is text-based. There's when Brady admits a patient and writes a history and physical note, the admission will have some type of ICD-10 diagnosis. And so there'll be some textual information there tied back to an ICD-10 code. I don't know, I've not extracted notes from a analytics perspective. I've never extracted text notes to see if they tie ICD-10 codes or really any kind of clinical coding to the note. Whereas basically you say, like, this note is a text-based note, but it also contains these codes, these CPTs or ICDs, whatever it may be. But it's a combination of pure text that would require NLP to like pull data out of it, as well as those macros where you say, no, go get me the data from the lab, that discrete data that we already have stored somewhere else, just put it into text-based form that's readable for the human. And that data is generated combination of keyboard shortcuts and voice dictation. So Dragon has a whole medical app for it, and Epic has their own like speech recognition thing. So I usually will see, like, physicians will have their phone and they're talking and it's transcribing in real time, and they're also managing their macros on the keyboard. So.
Yeah, and for physicians especially, there's a lot of flexibility because a lot of physicians like to do things a lot of different ways in terms of notes. So that actually makes it even more complicated, I think. So that's why you have different formatting of, probably why it's harder for you to read provider notes, because they're not all following the same formatting either, in terms of where things go and how things are. And to add to that templating, what's also nice too is that you can do what Robert said, but then you can come back the following day. Let's say you see that patient the next day, you can just copy that entire template with all the information you had from the prior note. Then it updates all the templating stuff, like the medicines, the labs. So all those sections get re-updated even though you're copying the notes. So that's sort of where things are, at least for a lot of provider notes at this point.
Note writing in OpenEMR is something I would love to tackle it, and really build a bigger, more comprehensive noting solution. I think we create a lot of LBFs that do not need to be LBFs. We capture a lot of text-based notes. If we just had a note writing platform and then you just had a note, oh man, it would be so much more powerful. And I don't think we're really that far off. It's just there's a tremendous amount of flexibility that you have to bake into the system, which makes it a little, it's not cut and dry by any means. But I have noticed there's success when you build a template and you enforce template using across the board. When a physician can't go rogue and everybody can write their own note, but when they just start with a pre-built template, then it does make it a lot easier. Yes, I have to peruse over information I don't care about, but I can almost always I know where it is because it's the same format every time. I can get there and find the plan pretty quickly. I didn't know Dragon discontinued their medical application. Oh, part of the regular. Oh, that's cool.
Yes. Yeah, I had it, excuse me, I used it about up to a year ago to a year and a half ago. And that was a message that I had. They just merged it, I believe. I mean, I still have it. I just don't use it much anymore. Regarding writing notes, OpenEMR has it all. I think that the issue is organizing some of it is data that needs to be entered into the database, and some of it is our observations that we can put into any space. I mean, be it a progress note like the old SOAP note, or the layout based type progress note. So that we put that, then we put that information into these boxes, right? This text information, that information then gets entered into the database. But I think we're getting confused. We're getting what we do as physicians and providers, we're getting it all confused. Once we enter the data, that could be in any box, but then say specialists have to write up a report that needs to go back to the primary care doctor, right? Then that's a report. So I think that what we are needing, let's get organized and call it by the way it should be called. What you are looking for and what you are calling a note is really a formal report of the visit. And so that can be done by us making templates for the report and then adding the little pieces of all the data gathering we have accomplished. I think that's because OpenEMR does have everything for note writing. I think it's just the way we're looking at it that we're missing it. We're missing sight of the forest for the trees, I think.
I think that's a good observation. We call everything a form. And I don't think that is, we can.
Exactly. That was going to be another point of mine. Go ahead.
We can better categorize, a lot of the assessment data that I do as a nurse, it's on a flow sheet. It should be on a flow sheet. We should call it a flow sheet. That's what it should be. That's what it was before the EMR existed. That's generally best practice today. But we call it a form. And then you write a progress note as a physician, we call it a form. Well, it's a progress note.
It's really a report. It's
Has,
really a
has,
report of my encounter.
has anybody
I
even looked?
am terrified of OpenEMR becoming flow sheets because I'm not used to looking at flow sheets. I'm sorry. I realized I was interrupting someone else.
Has anybody even looked at my new clinical notes form?
I'm not, I haven't, I don't think. I was going over the video that I found your presentation on the new patient portal.
No,
And
no.
and I
No,
have
I'm
some
talking-
comments on that, but I haven't looked at the new ones. I haven't been able to get there. I'm sorry, I'm a little slow.
That's all right. Maybe I ought to do a presentation on that new stuff. Because I added new, what you want to call form, but it's all categorized as clinical notes. So I don't know if you've seen that, Robert, but I do want you to go look at it and give me notes on it. I've been waiting for somebody to do that because, you know, I kind of did that in the dark, following the spec for what was needed for a CCDA, etc. But
Yeah,
whether it's practical or not to working nurses, physicians, or what have you, I don't know. So I need feedback on that. And it's been there for almost a year now. So
oh, I did not know that.
yeah,
I'll do a deep
Otherwise I
dive
would
into it, Jerry.
Otherwise I
I'd
would
love
be
that,
missing it.
Robert, if you would. And
Yeah.
then just shoot me some notes on it. I'll be happy to go fix it. But
Yeah.
I tried to get it close to where at least when you do a note, you know what the note's for, whether it's a nurse's note, a provider note, or if it's an assessment or what have you. It's not a SOAP note per se, but it's just clinical notes. And it tracks by who's doing the note, i.e. it's not the login user, it's going to be, well, it'll be the login user, but if you make the note, the next time another person comes along, they look at that note and they know who made the note, where previously that wasn't true. But anyway, just go take a look at it, make notes, and let me know, and I'll finish it.
Yeah, I definitely will. That'd be great. And then Sandra and Brady, if you guys want to check it out too and just do some trialing, just that way we get some cross coverage to see how it is.
Yeah, I would love to do that. This is in the latest patch, or how do I get to that?
Then definitely 6.1. I don't know if I brought it back to 6.0 or not. I might have. I tend to bring everything back, which is a good thing and a bad thing.
We added
Well,
it
is
as
there-
part of CDA and the firework that we did.
Yeah.
Because there's a
Is there a
2015
demo? Because I could check it out in the demo too.
yeah.
It's
I'm
in
not
the-
sure if there's a demo. Sounds like we need to make one, right?
There's a developer.
Gary?
It's in the developers demo.
It'll be in the development demos. It'll just be a form that you can, it's listed as one of the, on the encounter, one of the forms that you can use.
Yeah, it's called clinical notes.
Okay.
It has the 9 that's required, or the 8. I forget how many is required. But also you can pop up our nation note inside this, except it's text-based nation notes, and add ICD-10s or SNOMEDs or what you need to add to the note based upon medical problems, medications, medical devices, et cetera, et cetera. It's pretty cool if it gets documented and people use it in the way it's documented, but I don't know if it replaces a SOAP note or not. And I still don't understand, a lot of people use SOAP notes. If they use SOAP notes, then they're not going to use the clinical notes, et cetera.
So a SOAP note is really nothing but a progress note that follows a very specific format.
Right.
It could be, and I'm looking at it now. I pulled it up in my local demo, and yeah, I mean I think this is the start. I think this is where we start.
Okay.
I'll try it out. I'll give you some feedback. There's a few things. I don't have a ton. I haven't done a ton with nation notes. I need to. I just need to do it and like really deep dive.
Well, you
yeah,
double click anytime you're in a text box in encounters. You can double click that text box and get a nation notes, except it's text based. You can't use HTML or any of that stuff in it, but you can still use context and things like that.
We probably do need to land on, at least for the some kind of basic markup type system. Like we need HTML in the notes because we need to parse out some tables and tables of data, and there needs to be some structure to it. But yeah, no, I looked at it, and I'll deep dive off the call and give you some feedback. But that's definitely the start of it for sure.
Yeah, it covers what I need for CCDA, but I want it to be practical in production also. So
Yeah,
great. Just give me some feedback. Thanks.
So where do I find the developer demo? Is that I'm in the demo page, and I just see OpenEMR 6.0.0 main demo, and then alternate demo and another alternate demo.
I don't know.
If you go to the top of that screen, you'll see a paragraph going like a quick overview of the demos. And you'll see a
right, for
development.
the most recent development
you'll
demo. Oh my
You'll
God.
see a
yes.
development demos link. That'll take
Yeah,
you to
yeah,
it.
yeah.
And there's a
It was
couple there.
there.
You can just pick one. Pick one probably with data, and it's always easier with demo data.
one thing, Jerry, I can tell you a thing that I see, revision history. We have to know who makes addendums and who makes edits. And then co-signing is another thing that I see a lot of. So say a resident writes a note, and then Brady, as an attending physician, oversees that resident. Generally, I see notes where Brady will jump in and write an attestation saying that, yes, I reviewed the patient independently, this note is appropriate, and then they co-sign the note. So
in the same note, they would make a new note referencing the old
correct.
note, right? Okay.
No, they're co-signing the same note. They're saying this note written by this resident is good. I say it's good, and it kind of ties together like that. In addition to the revision history.
I don't stop somebody else from editing it, but however, you won't. Yeah, the revision, you won't know who did the edit unless you put it in the note itself. So that's not tracked in database anywhere. It probably should be. I guess is what you're saying.
Revision history, yes, and then also who signs the note, because just because I write the note does not mean that I'm the one signing the note. I can write a note and Brady can sign it, and then.
So we'd have to e-sign each note.
Potentially, yeah, because a lot of in the emergency room, physicians don't write notes. They have scribes that are writing notes on the fly, and then the physician just basically is the signer.
Yeah.
Yeah.
Well, that wouldn't be too hard to do.
And our e-sign, I don't put my password into e-sign anything. When I hit the sign button, it's just, if I'm logged in, it's signed.
Right, but for
yeah, that kind of depends. The problem with OpenEMR is that once you sign it, you can't get back in. Whereas in like the newer way of doing things is once you sign it, it's pretty easy to just say make addendum, and you can edit the whole note again.
no, I thought e-sign
So it's a little different now these days.
I thought e-sign allowed you to do like a soft sign.
You can do an addendum, but you're adding something on to the end of it. You're not like, you can't go into that note and modify it after you e-sign it.
Yeah, but we can fix that.
Yeah, so that's the that's why it's good to have a little bit more level in that case where you do have to, rather, because if you click it by mistake, then you can't go back and edit it anymore.
Yeah, this is very helpful.
May not need a password though. You could just say, "Are you sure you want to do this?" type of thing.
I don't even know if, I don't think I sign notes as a nurse. I think I just save a note and it's unsigned. I think you sign. Yeah,
I have to sign, and then but once I sign, I can addendum, which means I can essentially edit it anything I want again, and then I re-sign it. That's how notes, at least that's how I see notes are working now, like in the practical setting. You don't really, it used to be that when you signed it, you would have, but we still kind of follow that thing. If we make a change, we usually sometimes we'll put like an addendum at the bottom of the note, like to make it clear, but not always, but everyone's different. But it's a little more flexible now, and definitely having a history of changes is important too. So that would be a good thing to put high on the list of things to think about supporting.
I wonder if we could just do a like revision history could be hashed, right, Jerry?
Yeah.
I don't want to talk about technical details, but
right. Yeah, but I have a better understanding now. That's what I needed when I was doing this, but was so busy doing everything else. But I can go back and readdress that, because just these notes I've gotten so far, it shouldn't be too difficult. At least maybe get it into 6.1, hopefully. At least
Yeah.
that, I don't know, it would improve it, that perhaps people will use it. That's what I'm worried about. People won't use it. And they need to use, if they're going to use CCDA, etc., or FHIR, because that's where we gather all our data to report in CCDA and FHIR is from those clinical notes and the care plan, which also has assessments, goals, things like that in it. So those need to be used if you're going to use CCDA. And that's the reason I really want to make that work the way it needs to work, is so people use it so they can use the CCDA and the CQM. So, okay, thanks.
Hey, Brady, is it possible to pause recordings, or is it a start stop and then that's kind of just it?
Yeah, it's better probably start stop if we're ready to stop, since you've gone an hour, almost an hour and a half.
Well,
what are your thoughts? Do you want to finish up things, or?
Yeah, I mean, I think this has been a very productive conversation. At least, I don't know, maybe I'm wrong, but I want to share something, but it needs to be off the record.
Oh, off the record?
Yeah.
I mean, we could always
pause or just stop.
I could pause, but then we kind of jump. I mean, unless we feel like, do you want to keep going after?
No, I'm good. I've covered everything. I think it spurred a conversation that I wanted it to spur.
Oh yeah.
So I think it was good. So yeah, unless there's anything anybody else wants to add, I think we can wrap this one.
So anybody have questions? Otherwise, I'll stop recording. Looks like on the chat we have someone saying this has been very informative and you've been wonderful. So we'll end on that.
Thank you.
Yeah.